Okay, so now we're going to talk about preterm infants. Remember that preterm labor is the most common complication of pregnancy. Preterm infants are, preterm is probably the most common complication in the newborn period. So we're going to have several sections on preterm infants because we're going to get a little bit granular about what the effects are on different systems. First of all, the first thing you need to know is the prognosis of preterm delivery, preterm birth depends on the gestational age very heavily, but also on what else may be going on, what comorbidities that infant may have. There is a category that we call late preterm. We used to think after 34 weeks, everything's fine. Kind of after 32 weeks, the survival rates are about the same. But between 34 and 37 weeks, babies are born and they still have a risk for respiratory distress syndrome, hypoglycemia, temperature instability, poor feeding, jaundice, and delayed discharge or having to be readmitted to the hospital. Those babies are likely to survive, but in the past we underestimated how often they have morbidity or sickness. And it's really just how often they need a little extra help to adjust to life on the outside. So we need to be assessing those babies carefully. What does prematurity, what does being premature do to different body systems? You've got to go back to fetal development. What is happening at different stages of fetal development? That's really going to be important when we talk about cutting that off. If we begin to build alveoli at 23 or 24 weeks, then before 23 or 24 weeks, that a baby is not going to have the ability to exchange gases. If we start to make surfactant at 32 weeks, then babies born after 24 weeks when they can make some alveoli, but before 32 weeks, are going to have respiratory distress syndrome. Surfactant production gradually increases. So at 32 weeks, they're not making as much as they need. They're making some. They're making more at 34 and more at 36. But the closer they get to delivery, the less the risk of respiratory distress syndrome. But it's because they're increasing their surfactant production. So to understand what the effects are, we've got to look back at what's supposed to be happening before, after, and at that stage of gestation. So the appearance of a premature newborn, clearly they're usually going to be small because they've had less time to grow. They tend to appear to be very thin because they haven't had time to put down subcutaneous fat. Remember, in the last 4 to 6 weeks of pregnancy is when they really start to plump up and build some subcutaneous fat layers. Their skin is thin and translucent. Very preterm babies, their skin is actually gelatinous and tears very easily. Lanugo. Remember when the lanugo starts to be formed and then when it starts to mostly be all rubbed off and there's not much left. So in a micro preemie, those very tiny preemies or very early preemies, they won't have any lanugo. And then a little further down the road, they're going to have a lot of lanugo. And then as they get closer to term, it gets rubbed off as they're moving around in utero. And so they're going to have sparse lanugo. So we want to look at lanugo to give us an idea of how early that baby is. Vernix, again, is really thick in premature babies. The micro preemies may not have much, if any. Those preemies are going to have a lot, and then nearer term, they have less lanugo. The ear cartilage continues to firm up in the last weeks of pregnancy. So the ear cartilage for preemies is going to be softer and their ears may be much more flexible. The creases on the palms and their soles tend to become more abundant as they get closer to delivery. So if they're born before term, they're going to have fewer creases on the palms and soles. The same thing with scrotal and labial development. They get more scrotal rugae the closer they get. If the testes descend late in pregnancy, that means premature babies are more likely to have undescended testes. The labia majora continue to grow to cover the labia minora in late pregnancy. So if the baby is born preterm, they may be the same size. So think about the general appearance things. Also, a term newborn is usually in an attitude of flexion. They're usually flexed. Preemies may not have the muscle tone to do that, so they may be more extended. Now, I want you to remember those things when we start talking about the effects on how they function, the effects on physiology. The neurologic system, a term newborn learns in the first day or so of life to coordinate suck, swallow, and breathe, okay? They have to be able to coordinate those things to eat and breathe. Preemies are not meant to be out yet. They're not supposed to be feeding yet. And so they have a harder time with that coordination. So their suck and swallow may be weak and they may be uncoordinated. So it takes more energy to get food in them. Okay. It takes more energy for them to feed by mouth because their muscles that are supposed to be doing that are not developed well yet. And their neurologic system is not developed to coordinate that yet. The respiratory regulation center is immature, so they may have pauses in breathing because they're not supposed to be breathing yet. So they forget to breathe. The skull is softer, and so they're more likely to have skull molding and positional plagiocephaly, which is when instead of being in water or in fluid, they're out on surfaces. And so if that baby is laid flat on its back, in under a warmer for several weeks because it's unstable and needs to stay in that position for care, it's likely to develop a flat spot. Or if it's turned with the head on one side or the other side. So when babies are stable enough to do so, they want to turn and change the position of the preemie's head to prevent those flat areas. That's a very common problem. It's called positional plagiocephaly. The blood vessels are fragile and they have less protection. And so a blood vessel being disrupted is more common. If that happens in the brain bleeds are more common, okay? Child development is assessed based on that child's adjusted age when they were supposed to be born until they're around 3 years old. So if they're born at 32 weeks, then at 2 months of age, that's when they should have been born. So at 4 months of age, we're going to compare their development to a 2-month-old. Okay, so I want you to think about that. Until about 3 years old, we base their developmental assessment on their adjusted age when they're supposed to be out. The respiratory system. So the thorax is softer and more pliable, and the lungs are softer and more pliable. That means that there's less resistance, okay? They may have periodic breathing with periods of apnea and hypoventilation because the neurologic system is not ready yet to say breathe all the time, consistently. So they forget to breathe. The lungs are immature. They have less surfactant. If it's before 32 weeks, they may not have much surfactant at all. Extremely preterm. Remember, we start making alveoli at 24 weeks, but we keep making new ones for a while. So if they're born at 25 weeks, they have fewer alveoli. So very immature may have fewer alveoli for gas exchange. So how do we manage those things? We want to protect their airway, lessen oxygen demand. So we don't want to do things that make them need more oxygen. We want to minimize the oxygen demand as much as we can and manage respiratory distress syndrome. And we're going to talk about RDS a little bit later. The cardiovascular system. So when the baby is born, remember that we've been bypassing the lungs in fetal circulation. When the baby is born and takes a breath, we're talking about a full-term baby now, the increase in oxygen level causes the vessels that go to their lungs to relax. At the same time, that breath inflates their lungs. And so that lowers the pressure on the right side of circulation, okay? While that's happening, the cord is clamped or cut, And so that increases the pressure because there's less space to put the blood in on the left side. So in utero, we have a normal, a physiologic right to left shunt. There's more pressure on the right, so most of the blood shunts over to the left for general circulation. Remember that shunt. Okay. So at birth, the pressure on the right comes down because the lungs inflate, so that's less pressure, and the vessels relax. The pulmonary arteries relax, and so that's less pressure. So that pressure comes down. We cut the cord and remove it, so that brings this pressure up, and so they equalize, and that allows the foramen ovale and the ductus arteriosus to close because we don't have blood going back and back going through those anymore. But if they don't take those first breaths effectively because they're premature and they're not supposed to be outside breathing yet, and they don't relax those vessels, and the lungs don't inflate fully, then we still have more pressure here, okay? So even though we cut the cord and bring this pressure up some, we still have more pressure on the right. So they have a persistent right to left shunt. And I want you to take a minute, pause if you need to, take a minute, draw that on your paper or your whiteboard and make that make sense to you. If the pressure doesn't decrease in the pulmonary vessels, and if the lungs don't inflate well, then the pressure stays high on the right side of circulation and they have a persistent right to left shunt. So if that happens, then those openings, the foramen ovale and the ductus arteriosus, stay open instead of closing like they're supposed to. So what if the lungs do open, they do get a breath in, and the vessels do dilate? All right, so we cut the cord, left pressure goes up, the lungs inflate, blood vessels dilate, right pressure goes down. Now, the lungs are softer and the vessels are softer, and so the pressure may actually go down even further on the right side. So then we can have blood going the other way, left to right shunt, blood going from systemic into the pulmonary circulation. So they can have either a right to left or left to right shunt because they're premature, and it's going to depend on whether their pulmonary vessels relax and whether the lungs inflate well. Okay, so right to left or left to right. Either way, if blood is still going through those openings, they don't close when they're supposed to. So that can lead to a patent ductus arteriosus or a foramen ovale that fails to close, which is an atrial septal defect. Okay. Management for cardiovascular. Again, we want to minimize their oxygen demand. We don't want to ask a lot of these babies. They're using every bit of oxygen and glucose that they can get in to survive, and we don't want to upset that balance. We want to manage their fluid balance because they can actually get congestive heart failure. If we have blood that's supposed to be going into regular or systemic circulation and it goes over through the pulmonary vessels, we can have fluid overload, okay, in the lungs. So we can have pulmonary edema. So we want to manage their fluid balance. We want to manage that pulmonary hypertension. If these vessels don't relax, then things are going to be done to try to relax them so that blood can get through them. Okay. Indomethacin may be given if the ductus arteriosus does not close when it should. So they may give indomethacin. All right. So I want you to take a little time, go back and re-listen to this, draw pictures, write it out, whatever you need to do. But I want you to take a little time to think about what the effects of being premature are on the neurologic, respiratory, and cardiovascular systems. Okay, and then you're going to move to the next section, which is going to start with GI.